Welcome to this explainer. Let's just be real for a second about the reality of the outpatient clinic. You've got a completely packed schedule, super complex patients, maybe 15 minutes a slot if you're lucky, and right in the middle of all that chaos, you're somehow expected to be an amazing, inspiring teacher to your resident or medical student. Honestly, it feels impossible sometimes to balance patient volume with high-yield clinical teaching. But there is actually a very specific, evidence-based strategy to fix this, and it's all about what we call the Educational Alliance. Today, we're going to look at exactly why setting expectations up front is the absolute key to unlocking effective clinical training, and we'll walk through two real-world examples of how to employ this technique without completely destroying your clinic schedule.
Okay, let's dive right into this. Here's our agenda. First, we'll define the Educational Alliance. Second, we'll unpack why setting those expectations actually works. Then we jump into our examples. Example 1 is SnapPass, and example 2 is the 5 microskills. And finally, we'll wrap the whole thing up with debriefing the encounter.
Section 1. The Educational Alliance. Transforming the busy clinical environment.
Look, we completely validate how tough it is to balance your primary duty of patient care with your responsibility to teach. But the secret here? The solution doesn't actually happen during the patient encounter. It happens before it. It starts with building rapport and setting crystal clear expectations up front to form this educational alliance. And to really get why this matters, we have to put ourselves in the learner's shoes for a minute. Think about this quote. It can be quite demoralizing to have worked really hard on developing new clinical skills and then basically be told to stand in the corner and observe all day long. I mean, we've all been there, right? That incredibly awkward phase of just standing silently against the wall, trying not to breathe too loudly, hoping you aren't in the way. If we don't proactively engage our learners and give them a defined role, they just default to being passive observers. And let's be honest, passive observation is a pretty terrible way to learn medicine.
So how do we fix this? You do it by using a quick preclinical encounter conversation. A lot of folks call this a learning huddle. Right before you start seeing patients, just run through this super quick checklist. First, introduce yourself and orient the learner to the clinic's workflow. Second, make it a two-way street. Elicit some information about their background and their prior experience. Third, set realistic, highly specific goals for the day. Like maybe today's goal is just practicing focused social histories. That's it. And fourth, establish psychological safety. Tell them explicitly that you actually want their questions and curiosity. Taking literally 3 minutes to do this aligns your goals and transforms that student from a passive bystander into an active participant.
Section 2. Why setting expectations works. The science of adult learning and safety.
Now that we have the what, let's transition to the theoretical why. Because the Educational Alliance isn't just some nice feel-good buzzword. It is deeply rooted in the science of adult learning. It works because it directly aligns with how our brains are actually wired to learn. And this brilliantly illustrates the complete split in how we learn, as mapped out by the educator Malcolm Knowles. We essentially have two operating systems. Pedagogy is how children learn. They're dependent, they're blank slates, they're motivated by external things like grades, and the teacher is the absolute authority in the room. But medical students and residents, they use andragogy, which is adult learning. They're independent, they bring a lifetime of experience with them, and they desperately need problem-centered, practical relevance. Their motivation is internal. They view the teacher not as a dictator, but as a guide or a facilitator. When you set expectations and form that alliance, you're treating them like adults. You're respecting their independence and stepping perfectly into that guide role.
A massive, absolutely crucial part of that adult learning framework requires psychological safety. Basically, this is the belief that you won't be punished or humiliated for speaking up with ideas, questions, concerns, or, and this is the big one, mistakes. When you set expectations up front during that learning huddle, you are explicitly lowering the psychological costs of speaking up. You're giving the learner permission to say, hey, I actually don't know this, without any fear of retribution. And honestly, that protects patient safety just as much as it promotes learning.
Because when we put all this together, it's just magic. When you maintain high accountability for patient care, which you have to because the standards of medicine demand it, but you combine it with high psychological safety, you push the student directly into the highly effective learning zone. They aren't paralyzed by anxiety, and they aren't just drifting in the apathy zone either. They are fully engaged and ready to tackle complex clinical reasoning.
Section 3. Example 1. SNAPS. A 6-step learner-centered approach to clinical teaching. Let's pivot to the practical application. How do you actually guide a learner through a patient presentation efficiently? Well, our first concrete, evidence-based framework tailored specifically for busy outpatient clinics is SNAPS. Let's walk through these 6 steps to demystify the acronym. First, the learner summarizes the history and findings, briefly.
Second, they narrow the differential to just 2 or 3 possibilities. Third, they analyze the differential by comparing and contrasting. This is great because it's where you get to hear their clinical reasoning out loud. Fourth, they probe the preceptor by asking you questions about their uncertainties. Fifth, they plan the management. And sixth, they select an issue for self-directed learning to look up later. What's brilliant about SNAPS is that it hands the keys over to the learner to drive the oral case presentation. It completely stops that endless, rambling presentation and keeps the encounter super efficient, problem-centered, and tightly focused.
Section 4. Example 2, 5 microskills. Precepting with limited time.
Now, if SNAPS is driven by the learner, our second tool is driven by you, the teacher. When your time slots are heavily constrained, which is basically always, the 5 microskills framework is designed to inject really high-yield teaching into the conversation in just a matter of minutes. So the crucial point is how quickly these 5 steps allow you to assess and instruct. Step 1, get a commitment. Just ask them, what do you think is going on? This forces them to actually process the data, not just read it back to you. Step 2, probe for supporting evidence. Why do you think that? Step 3, teach one general rule. And this is a true microskill, right? Don't give a 20-minute lecture. Just give one concise, memorable learning point tailored to the case. Step 4, reinforce what was done well with specific praise. And Step 5, provide coaching to correct mistakes and discuss a quick plan for improvement. It's a rapid-fire way to guide their clinical reasoning and provide immediate, actionable feedback without throwing your entire clinic schedule off track.
Section 5, debriefing the encounter, closing the loop on learning.
Okay, so we've set the stage, we've executed the teaching, and now we move to the final phase of the clinical day. The Educational Alliance absolutely requires closing the loop to make sure those upfront expectations we established in the morning huddle were actually met. Keep this punchy checklist in mind for your post-encounter wrap-up. Think of this as a rapid, effortless closing routine, not just another chore on your list. At the end of the session, take just a couple of minutes to debrief and reflect on what the learner observed. Address any remaining questions or concerns that might still be kind of lingering out there. Agree upon the next steps for their continued learning and clarify any follow-up expectations, like maybe having them read up on a specific pathology before tomorrow. Summarizing the encounter like this cements that learning right into their long-term memory and builds their resilience for the next patient.
We've covered a ton of ground in this explainer today, from the basic theories of andragogy all the way down to the practical steps of SNAPS and the 5 microskills. Now that you essentially have the owner's manual for adult learning, how will you choose to build an educational alliance in your clinic tomorrow? Remember, investing just 3 to 5 minutes upfront to set expectations drastically improves your learner's autonomy, lowers their anxiety, makes your teaching way more efficient, and ultimately protects the safety of your patients. Try running a learning huddle tomorrow morning and just watch how it transforms your clinic flow. Thanks so much for learning with us.